everyone. Thank you for participating in our Desert Run in the Family training. My name is Vaughn Edelson. I'm Assistant Director of Health Communications at Genetic Alliance. We're excited that you're participating with us in our efforts to increase family health history awareness and conversation in the healthcare setting. Today I'll be presenting the Desert Run in the Family Toolkit as well as some background information on this project, and then I'll be turning it over to Emily Edelman from the National Coalition for Health Professional Education in Genetics, one of our partners, to do a presentation on family health history and genetics and how to identify some red flags. So our learning objectives for the day are first to understand the content and the intended use of the Desert Run in the Family Toolkit, which consists of 2 booklets, a guide to family health history and a guide to genetics and health. And then we'll go over benefits of using family health history both in the clinical setting and in the community setting. From there, I'll turn it over to Emily, who will cover how to create a pedigree, how to identify genetic red flags, where to locate various resources and tools on both family health history and genetics, and then how to interpret family health history in case examples. So why did we do this project? Why a focus on family health history? People know it's important, but the majority of people are not acting on that knowledge. This CDC survey is several years old at this point, but they found that of 4,000 individuals, about 97% of people thought that knowledge of family health history was important, but only 30% had ever actually collected family health history information from their relatives. And so for those people who have actually collected their family health history, without appropriate support and engagement, they're not necessarily changing their behaviors based on what they know. Family health history has been called the most basic genetic test. It takes into account what runs in your family, and using that information, you can assess your risk for developing certain conditions. So you can identify trends and patterns of disease. It allows a healthcare provider to diagnose conditions and understand risk. But beyond just what runs in the family, it captures the diet and environment, your behaviors, your lifestyle, all in one place. And so the evaluation of an individual's family health history is the first step to identifying genetic contributors to your health, and it can serve as a basis for encouraging a healthy lifestyle. So this makes it a useful tool both in the clinic and in the community setting. An important part of this project is that last bullet on promoting conversations about health in the family and community. This project is really about patient-provider communication around family health history, and so that's an important focus. So why family health history in the clinic? It's important for diagnosing and assessing risk, both for rare single gene disorders as well as common complex conditions. There are a lot of hints for health that apply to pretty much everyone. Eat a healthy diet, exercise regularly, don't smoke. But looking at your family health history allows healthcare providers to personalize the prevention, management, and treatment recommendations beyond universally applicable healthy living recommendations. In addition, as we've already said, family health history can help detect, manage, and prevent disease, but it also creates an opportunity for patient education. And beyond that, it can help build a rapport between patients and providers, establishing a partnership for care rather than a one-way relationship where the patient is just the recipient of the information. It creates more of a dialogue. Similarly, family health history is also a very important tool in the community. There's still a lot of stigma in many families and communities around health. So family health history conversations that incorporate lifestyle, diet, exercise, culture, and other aspects of your daily life in addition to the health topics can help break down some of the conversation barriers. And as we've just said, the family health history knowledge can help individuals be real partners in the management of their care. So the family health history is one of the only things during a visit that a patient will come into the office knowing more about than their doctor because it's theirs. This gives the patient, a level of authority for the interaction and can create more of a dialogue. So it empowers people to be the stewards of their own health and to really participate. So we, for this project, have seen family health history as the link between people's daily lives and their health, as well as the bridge between health and genetics. We found that genetics can be an intimidating word for some people, but bringing it up as what runs in the family is more palatable. Family health history as a concept offers many unique access points to the information. So, we think of the interaction in the doctor's office, but it's not just that. It is more. It's about the environment, the lifestyle, the culture, and the family relationships. These conversations really should start at home with the culture and the relationships you share with those around you. From there, it can build to the community and to the clinic. Along the same vein, we think of these conversations in the clinic, in the hospital, but they can happen in different settings with different groups of people at the gym, through an employee health and wellness program, in person, through online communications. This project is several years old, and we've worked with many different community-based organizations who tested out the family health history booklets and this method of communication in various settings, and I'll kind of get to the evaluation of that project in just a second. Finally, these are just a sample of some of the ways our partners on this project have engaged their communities to talk about family health history. Health shouldn't be a burden and really can make it engaging. Many people do love to share their stories, and so people have used contests and different fitness activities and other programs to get people motivated. So the toolkit itself that you'll be using or that you already are using in the health centers is called the Does It Run in the Family Toolkit. It consists of these two booklets, a guide to family health history and a guide to genetics and health. And these were developed several years ago, in 2006. And when they were being developed, we had kind of these five bullet points that were the focus. So accessibility is a big one. This is meant both in terms of the content of the booklets and their physical accessibility. So we wanted the content to be accessible across a range of different communities for a variety of folks, individuals, families, communities, to be able to understand and relate to the information inside. But we also wanted to make it accessible, so there's a PDF version that people can email, post to your website, or there's the print copy that you can hand out to patients and they can then pass on to family members. There was a lot of community input that went into the development of these booklets. All of the original partners on the project had community advisory boards, and individuals and families helped customize the booklets and provide their input on their development, and that's what all of our health center partners on this project have done as well. They've collected the stories from your patients, from your community members, to put into the booklet so that they can feel a part of it. The booklets were formally evaluated in several communities across the country, and I'll tell you a little bit about those results in a minute. And they were informally evaluated by many more. We've had over, dozens, really, of partners on the project so far over the past several years who've looked at the booklet from a health literacy perspective, from different communication perspectives, and we've found that they are pretty accessible, which is good, across different types of communities. The next bullet is sustainability. They were designed to be integrated into ongoing initiatives. We never meant for anyone to build whole new programs around these booklets. We wanted the family health history conversations to be complementary to and integrated into activities that were already ongoing. And in this way, we thought that it would be more likely to remain sustainable after initial project funding is over. And the last bullet, resource sharing, it is meant to be a tool that gets passed around. It doesn't sit with one person. It's a conversation starter, and it's meant to be complementary to many other tools that are out there. So the online version of the tool is at familyhealthhistory.org. That allows anyone to go in and customize the booklets in either English or Spanish. We're hoping to do other languages. We're not quite there yet, but you can put in your own stories, health condition information, resources, And here are the specifics. So for book 1, it's focused around collecting, organizing, and understanding family health history. What is family health history? Why is it important to know? And how do I approach my family to collect this information? You can customize the personal health stories and photographs, as well as quotes and interview questions. The stories in particular we found really make the booklet accessible to people. If someone opens it up and they see someone in there who looks like them, who has a story that's similar to theirs, it becomes more relatable. In book 2, there's a little bit of Genetics 101, just the basics, and then several examples of conditions that run in the family. Heart disease, asthma, diabetes, cancers, but you can customize those conditions to include information for whatever conditions your community is most affected by, whether that's kidney disease, mental illness, sickle cell. We have a whole host of conditions in the library of the online tool that you can choose from and then customize, or if there's a condition that's prevalent in your community that's not in the online tool, we're happy to work with you to add it. And each of those condition pages has health condition information on the specific disorder, as well as risk statistics, hints for health, and then resources. And you can customize those to put in your own local resources with your clinic website or information, phone number, or other websites that you'd like to direct people to. So I put this slide in here as an example of kind of the current state of how people search for health information. There are a lot of great tools and information online. People are looking up health information online all the time, and it's great to have this information at our fingertips. A lot of it is really good information. Some of it is not, so you do have to be careful about what is credible and what isn't. But really, these booklets aren't meant to replace online searches. They're certainly not meant to replace the visits with your patients at the health centers. It's more about coming back to the booklets over time, revisiting the information, taking it in chunks, really digesting it, and having ongoing conversations with family members about health. You say print is personal. It's nice to have something that you can physically share with family members as a conversation starter. When patients get the booklets from your clinic, hopefully they will take them home, initiate conversations with the family, and then bring them back. Bring that information back to the clinic at their next visit. Share the information with your staff, with your providers to keep the conversation ongoing, update them about new developments in their family health history in order to contribute to the best care possible. So this is, I guess, an interesting thing to say to an audience of health center providers, but the booklets are not a point-of-care standalone tool. We certainly do not expect any of you to go through each and every detail in these booklets with your patients. They're long. They're about 20 pages each. That's 40 pages total for the toolkit. So there's no expectation that that will happen, at one visit at the clinic. The idea is to initiate discussion, to get people thinking, get people to understand the importance of knowing their family health history, relate it to the conditions that might have brought them into the health center in the first place, and figure out how knowing and understanding that information can help their health care to make them want to go home and talk to family and want to come back and continue the dialogue with their providers. The booklets are also complementary to tools like the Surgeon General's My Family Health Portrait, which lets you enter your family health history, but the toolkit gives you the how and the why behind those tools. So it's great that My Family Health Portrait gives you the means to put in your information. You can print out a nice pedigree or a chart that you can hold. You can bring it to your provider, but the booklets tell you why it's important to know this information and how you go about collecting it in the first place in order to be able to put it into the tool. So it's complementary to lots of existing resources. And back to the evaluation that I mentioned. In 2009, the booklets were evaluated in several diverse communities across the country. Each group recruited 25 families consisting of 2 or more blood relatives. They took a pre-survey on their beliefs about health and family health history. We didn't collect any health information. It was more questions like, how much do you think your mother's health influences your health? We asked some lifestyle questions as well. And then they received the booklets, talked to their families about them, and then 3 months later completed another survey, and we found significant changes in the measures that you see listed here. So hearing, talking about family health history with family members, sharing materials, reading materials about family health history. So good outcomes. The booklets did generate discussions. What we didn't find was a change in conversations with healthcare providers. And so there are many potential reasons for that. Perhaps there's a lack of provider trust in some of our communities. Perhaps 3 months was just not long enough to see that change. If you're a typical healthy person, you might not see your healthcare provider in any given 3-month period of time. And so that's one of the reasons why we're doing this project. From the community setting, we saw that it worked, and we wanted to take it into the clinic to see if it could have the same effect. So this project is in total about a year in the health center. So really, when it comes to actual dissemination and working with it, probably closer to 9 months for all of you. So we still won't be able to see changes in clinical outcomes, but we're hoping to get a better sense of the conversations that are occurring around family health history in the clinical setting. And so just kind of to sum up why we did this project, many people do not connect the stories of family illness with themselves. They don't make that connection to genetics, and people aren't necessarily comfortable translating what they know, maybe the stories they've heard from family members. They don't know how to translate that for providers. So we wanted to get at all of that, make people more comfortable with this information in order to facilitate better care and more dialogue with providers and staff at the health centers. So I will pause there to see if there are any questions. And if there are not, I will turn it over to Emily.
Can you see my screen?
Yes.
Okay. Well, and can you hear me okay, Vaughn?
Yeah.
Okay. Well, like Vaughn said, I'm Emily Edelman, and I represent the National Coalition for Health Professional Education in Genetics, or NCHPEG, and we've been delighted to work with Genetic Alliance on this particular project and this training session here. So I'm going to talk with you a little bit more about the clinical aspects of family health history, building on what Vaughn has talked about related to its benefit and importance and how it can improve management, how using family health history in clinical care can improve management for patients. And then we'll talk specifically about how to build a pedigree, a medical family tree, and how to analyze that pedigree and elect different interventions and management options for your patient based on risk assessment. I'll try to pause at a few points throughout the presentation to see if anyone has questions. And again, please feel free to type in the little chat on GoToMeeting if you have questions, and I'm sure Vaughn will interrupt me. So when we break down information conveyed by family health history, we see that family health history tells us both about shared genes in a family as well as shared environment. And genetics, genes and genetics can be scary terms for people, but if we can promote understanding and break it down into bite-sized pieces, it's less intimidating. So for example, when we're talking with patients and our clients about genes, a nice analogy is that a gene is an instruction manual for your body, and a trait is a feature that's passed down from generation to generation. So there are lots of helpful tidbits out there about how to communicate some of this information with patients, and as you work with your clients and talk with them about family health history and genetic conditions that might be running in the family, you'll develop your own portfolio of communication tips. So here we're looking at the risk that we can see running through a family health history, or risk that we see for a particular patient as a combination of a genetic risk and environmental risk. And genes may be outside of our control in terms of what we can change regarding our health status, but there are many aspects of health that are within our control, things like diet, exercise, smoking, stress, and others. And as I said a moment ago, family health history tells us not only about shared illnesses and genetic diseases that are running in the family, but it also tells us a lot about shared environment within a family. And we can see things like the foods people eat are going to affect, even though this is an environmental aspect of health, family members often eat the same kind of food, or family members are often all exposed to smoking in a house. So there are some of these shared environmental factors that we see as well clustering within families. So for the next portion of the presentation, we're going to focus on three overall categories of family health history, and those include family health history collection. We'll address some competencies within family health history collection, family health history interpretation, and family health history intervention, or what do you do with that information for your patient. These core competencies are based off of a set of core principles in family history for all health professionals that NCHPEG had developed in conjunction with the National Society of Genetic Counselors and other health professionals. And so there's a lot of information that we're going to cover, and I'll try to hit the high points and emphasize the important things. And you'll have this slide deck. This presentation is being recorded, so you can access this information later if you have additional questions. So family health history can be collected in lots of different ways. It can be recorded as a narrative, and we see some of that in this shot on this screen. It can be recorded as a graphic or as a pedigree, and it includes relationships between the family members and the diseases and health conditions present in a family. The most common tool used for recording family health history is this graphic called a pedigree, and that's what I have up on the screen here. We will keep coming back to this concept of the pedigree. So I'm just going to take one moment to talk a little bit about the symbols that you see here. There are many resources out there. We have some on the NCHPEG website and many other resources through NSGC and other folks about how to how to interpret these symbols on a pedigree. And these are some standard symbols that are used by health professionals all over the world to build pedigrees. So each individual in a family is represented by a shape or a symbol, and women are circles and men are squares. So you can see here the patient, or myself, is a female because she's a circle, and generations are lined up on the same row. So next to me I have my sister, represented by a circle, and my brother, represented by a square. These individuals, these siblings, all are connected by a sibling line. Above them are the parents, father and mother, who are connected by a relationship line. And you can see the family extends out. My father's family is on the left side of this particular pedigree. My mother's family is on the right side. And the same principles follow. Excuse me. My mother and her siblings are connected by a sibling line. So this would be my uncle and my aunt, and her parents are above her. And the same for my father. So you can build out a family history for generations and generations, and the visual representation can be very helpful in looking at conditions that might be tracking through a family. So as I just said, there are many different ways you can collect a patient's medical history, and once you collect it, there are many different ways you can organize it and display that information. But the critical element, no matter how you collect it, the critical information, whether it's a pedigree, a checklist, a table, something else, is the information that you're collecting. The method of regardless of which method you choose, it's important that the method of collection be accurate, be easy to update, allow for pattern detection and interpretation, so in thinking about how we're assessing the family history and interpreting risk factors. And it's particularly important that the method for data collection allows the healthcare provider to have clear communication and correct interpretation of a patient's family history between and among health providers. So it's something that needs to be intuitive not only to one single healthcare provider, but also his or her colleagues, or if the patient's referred to another clinic, something that can be transferred across clinic systems and across providers. So if we focus on the pedigree, as I just showed you on that diagram with the pink and the blue symbols, a pedigree uses standard symbols and standard terminology to represent what is actually a large amount of information into a visual representation or a diagram. And this is the preferred method for organizing and displaying family history, especially among geneticists. And my background is that I'm a genetic counselor, so this is how I was trained to collect and display family history information. But it's also the preferred method among other types of healthcare providers because it allows you to organize a great deal of information, and it allows you to visualize inheritance patterns and clustering of conditions in the family, which can be more challenging when you're looking at things in a chart or a table. So the first competency that we're going to focus on related to collection, we're focusing on collection, and then we'll talk about interpretation and intervention. The first competency related to collection is that healthcare providers should be able to produce at least a 3-generation pedigree or medical family history that includes the following features. And I'm going to talk about these different criteria on the next few slides. So the first thing is that we need to identify who we're talking to on a pedigree. That's an important point of documentation. So we want to identify the patient or the consultant, and we usually do this with an arrow. So in this particular pedigree, where we have a number of people in the family who we might be collecting information about, we put an arrow towards the person of interest who we're talking to. Another term for our patient is called a proband, and a slight nuance in terminology here is that the proband is someone who is affected with a disease. And we often color in a person in a pedigree who is affected with a condition of interest. So bottom line, you want to be pointing or drawing attention to our consultant or our proband, whoever the patient is who you're talking to. We also want to collect information about other relatives. So first, second, and third degree relatives, you can go beyond that, but the 3-generation and up through 3rd degree relatives is standard. We want to get information on both sides of the family, both the maternal side and the paternal side of the family. It's important to note what the relationships are in a family, whether someone's a full sibling or a half sibling, and that can become very important in certain situations where we're looking at conditions and how they might be tracking through a family. Equally important is to gather information about not only people who are affected with the disease, because that's important, but also those who are unaffected, because that provides us with context about how strongly presenting in a family a particular condition may be. So in this slide, we've highlighted different people in the family with colors to show their degree of relationship to our proband. So again, let's orient ourselves. We have a male proband, he's a square, and there's an arrow in front of him. So this is the patient who is presenting for care, who we're performing risk assessment for. In this particular diagram, we've colored in all of his 1st degree relatives in pink, all of his 2nd degree relatives in blue, and 3rd degree relatives in red. So the 1st degree relatives are people like parents, siblings, brothers and sisters, and children. 2nd degree relatives include aunts, uncles, grandparents, nieces, and nephews. 2nd degree relatives also include half siblings, and this is where it can become important to distinguish if someone's a full sibling or a half sibling. And in this particular pedigree, it looks a little clunky, but you can see this blue square over here is actually a half sibling to our patient because he's connected only through the mother and not through both the mother and the father. He's connected in a separate bloodline. And then our 3rd degree relatives include people like our first cousins, directed over here. And you can actually count this out. So if I want to look at my 2nd degree relatives, they're on a pedigree, they are away from me 2 steps. So 1, 2, my grandparent is my 2nd degree relative, or 1, 2, my nephew is my 2nd degree relative. For my cousin, I go 1, 2, 3, and it's a 3rd degree relative. As we said, it's also important to look at both sides of the family. There are some misconceptions out there that in some conditions only the mom side of the family is important or only the dad side of the family is important. I used to practice in cancer genetics, where I'd work with a lot of women who had a strong family history of breast cancer. And there were a lot of patients and sometimes health providers who thought that you only needed to worry about the mother's side of the family because we're talking about breast cancer. But that's actually not true. The paternal side of the family, the dad's side of the family, is as equally important when we're performing risk assessment for conditions. So some of the other information that we need to think about regarding collection, our second competency, is that healthcare providers should be able to elicit the following information for individuals represented in the pedigree. We need to gather some information about the relatives of the pedigree so that we can go to the next step of interpreting the pedigree or family history. We want to know how old people are in the family. We want to know about relevant health information like medical conditions they might have, the age at that diagnosis. If people have passed away, how old they were when they passed away, why did they pass away. Reproductive history can also be very helpful when we're assessing risk for genetic conditions or risk for infertility or fertility for a particular patient. So we want to know about the number of pregnancies, pregnancy complications, and if someone says, oh, my sister doesn't have any kids, we want to know if that was by choice or if that was related to infertility, because in some situations infertility can run in a family or be part of a genetic condition. So some ways to gather this information that we just talked about, especially honing in on some of the collecting information about medical conditions that might run in the family. Here are some questions that we can ask. Do any conditions run in the family? If we are interested in seeing if there are multiple affected family members, we can say, does anyone else in the family have the same or a similar condition? And as I talked about on the last slide, we're also interested in pregnancy complications, so you can collect this information about pregnancies in the family. We can also, in addition to pregnancy complications, we can also look at birth outcomes, because these are things that definitely can have a genetic contribution. We can see clustering in families. Does anyone in the family have a birth defect? We want to know about ancestry, and we'll talk more about that. So what country do your ancestors come from? And are any of your relatives or any members of the family related in any way? Are there any cases where blood relatives have had children together? And this is a term called consanguinity. We'll talk more about this in a moment as well. And here it is. So consanguinity, which is a complicated term if you've never seen it, it basically means marriage of blood relatives. And there are many different scenarios in which we can see marriage of blood relatives. Marriage between, or mating between blood relatives. Marriage and relationships between cousins is a common practice in many parts of the world, but it's uncommon in most parts of the United States, so we don't see it as much here. This is important to assess for, though, because children of consanguineous unions are at an increased risk for certain kinds of genetic conditions or birth defects. So they're at increased risk for autosomal recessive conditions and birth defects because close relatives are more likely than unrelated individuals to share some of the same variants through a common ancestor. And the degree of risk depends on the degree of relatedness. So in this slide, we have some different examples of excerpts of a pedigree that show consanguinity. Here we have first cousins. So these individuals are siblings right here, and they each had a child who then married. In this relationship, we have first cousins once removed. So this might be an uncle-niece relationship of having children together. And then down here we have second cousins. And when you're drawing a pedigree, if you identify a consanguinity, you note this by drawing a double line in the relationship, between the relationship that has consanguinity. So to wrap things up, some tips related to family history collection. We want to match the reported history of the patient with medical records. Sometimes people don't know much about the history, or they're not sure of a diagnosis, and we can sometimes confirm this by getting medical records on the individual at question. We want to collect information about unaffected relatives, as I said. Having 2 aunts with cancer might seem like a lot, for example, but if you also find out that there are 8 aunts and uncles without cancer, that provides some context for how strong is this cancer presenting in a family. Age at death is also important. people who have a younger age at death from a condition can indicate perhaps indicate a more strong genetic or inherited basis, as well as if someone died at a young age due to unrelated causes, like from a car accident, they might have passed away before they would have presented with the disease, so it can seem like a false negative in a family that this person didn't have a condition, but maybe they would have if they had lived longer, and so it's important to note if they died at a young age and what they died from. Okay, so I think we've gone over this information. Identifying the patient, getting information about first, second, and third degree relatives, and including information on both sides of the family. And now we're going to start putting all this information together. So here we have our family history structure, and now we're starting to put some of the health information in here. So you can see we've added information about current ages of those people who are living, ages at death, and causes of death for those who are deceased, and some basic health information. You see we have ages. Y0 is an abbreviation for years old or months old. And this is pretty standard documentation. You list someone's age. If they have a medical condition, you might write it underneath of them. If someone's passed away, we often put a line through that symbol to distinguish that they passed away and note the age at which they died. This person died at 54 years of age from an accident. At this point, we can also include some of the ages of diagnosis, and sometimes it can be helpful to color in people with particular conditions. So in this particular pedigree, we're using different quadrants of the individual symbol to demonstrate what kind of condition they have. And in a minute, we'll show you what a legend looks like, how you could define this. Here we're showing the addition of information about pregnancies and pregnancy complications and infertility. So here's an example of what it looks like if you're collecting information about whether or not someone had infertility or chose not to have children. So here we write, they did not have any children. There's no children underneath them by choice. We're also including information about ancestry here. So on each side of the family, the maternal side and the paternal side, we would like to know the ancestry. And this is important because the incidence of some conditions can vary based on the ancestry of the family. For example, sickle cell disease is more common in African Americans, while cystic fibrosis is more common in white individuals of Northern European descent. So knowledge of a patient's ancestry can help, especially if you see other red flags in a family, as we'll talk about in the next section, that can help you begin to think about things that might be more likely in a particular family, what conditions might be more likely. Knowledge of a patient's ancestry by no means should be the only information that you use in making a diagnosis, but it's included in part of a comprehensive evaluation of family history. And another thing to note that knowledge of the ancestral background or geographic location of interest, of origin, is more helpful than ethnicity because it's less subjective. So rather than asking individuals, what race are you or what race do you identify with, you can say, do you know where your ancestors came from? And here, as I mentioned, is an example of a legend or a key. This can be quite helpful when you are using symbols or different colors or different patterns to color in the individuals to demonstrate what conditions they have. So here you can see this individual has depression, and we've created a key that shows what this symbol means. Other things to record on a pedigree are the name of the person who collected the pedigree. So this is Jane Doe. This could be the doctor or a different kind of healthcare professional, and the date at which it was collected. And this is actually really important because family history information changes over time. Family history information should be updated over time when a patient returns for care, and it's helpful to know when was the last time you updated that family history information. Okay, so that wraps up talking about collection. And just to summarize some of the things that we've talked about with family history collection, we've talked about being able to generate or produce a 3-generation pedigree or medical family history. And we've talked about some of the different information that a healthcare provider can elicit to include on a pedigree, things like age, medical conditions, ancestral background, etc. So the next step is talking about, now that we've created this comprehensive 3-generation pedigree, what do we do with it? How do we interpret what we're seeing on a pedigree? So the first thing, the first competency or principle that we have in the interpretation of family history is that healthcare providers should be able to recognize genetic red flags. And healthcare providers use this idea of recognizing red flags and being aware of red flags all throughout medicine. So this is not a new concept, but some of the red flags that we think about for strongly genetic disease might be a little bit different. One of the so here we have a list of red flags, and I'll give you a few examples for some of them. One red flag is if you have multiple relatives with multiple affected family members with the same condition or a related condition. So if you have, and depending on the pattern here, this can help you think about if you are looking at an autosomal recessive condition, an autosomal dominant condition, an X-linked condition, which might run through only the females in the family. And we're not going to get into detail to all those different patterns, but documenting who is affected and then looking at the pattern can be an important red flag. If someone tells you that they have a genetic condition in the family, that's a red flag right there that you want to investigate further. If someone has an earlier age at onset of disease than expected, that's also a red flag. Common complex conditions that occur at an earlier age than expected can be more likely to have a genetic etiology. For example, breast cancer is very common in our population, and it typically occurs in women after menopause, postmenopausal. If you see breast cancer in a young woman premenopausal, that can be a red flag. Intellectual disability, or what we used to refer to as developmental delay or mental retardation, is a red flag for genetic disease. If people have, if there's a diagnosis in a less often affected sex, that can be a red flag. And again, I'll use breast cancer as an example. If a man has men can develop breast cancer. It's not common, but they can. And if a man develops breast cancer, then that's a red flag that perhaps there's something more strongly genetic going on in a family. And also, if you have multiple diagnoses or bilateral diagnoses in paired organs, like a bilateral breast cancer, bilateral kidney cysts, those are red flags. Additional red flags is if people have one or more major malformations or birth defects. It can be common to have a single minor malformation, which is a physical alteration that don't have substantial medical consequences. This can be due to normal population variance, but when we see more serious birth defects like congenital heart defects or clustering of individuals who might have cleft lip and palate and a heart defect, that can be suggestive of a genetic red flag. Diseases in the absence of risk factors or after preventative measures. Abnormalities in growth. Recurrent pregnancy losses, 2 or more, sometimes defined as 3 or more. A single miscarriage, especially in the first trimester, is very common or can be common. However, when we see a patient who has multiple miscarriages or a couple who has multiple miscarriages, that might be suggestive of a chromosomal change or another genetic alteration in one member of the couple that could be investigated. We've talked about consanguinity, and we've talked a little bit about ancestry, why ethnic predisposition can be an important red flag. And this diagram breaks apart this concept of certain conditions being more common in individuals of different ancestries. And the context for this particular slide is really thinking about preconception care. If a couple's considering getting pregnant, there are many different types of carrier screening for different genetic conditions that can be offered to them. And so this is a list of some of the genetic conditions that are offered to people of different ancestry. So for example, we talked about sickle cell disease is more common in individuals of African background, as well as some other ancestries listed here. Similar for the thalassemias, Tay-Sachs disease, cystic fibrosis, and then in addition to Tay-Sachs disease, a number of other conditions that we see occurring more frequently in individuals of Ashkenazi Jewish background. It's also important for healthcare providers to recognize some factors that you might uncover in your family history collection that can complicate interpretation. And we've listed these here, and sometimes they can be quite complicated, so it's important to recognize when they're there, to dig a little deeper, or refer out to a genetic specialist who might be able to do that digging. So sometimes when we have when you gather a family history and it's a pretty healthy family history, it seems pretty healthy, you might say, oh great, everyone's unaffected, this is good information. But you need to sometimes talk with the patient a little further to see, are we talking about missing information? Do they just not know anything about their family? Are they estranged perhaps? Or are these individuals truly healthy? And that can be kind of a subtle nuance sometimes that needs some additional questioning. It's important to consider the reliability or accuracy of information when interpreting a medical family history. Some patients are not great historians or may again remember misinformation or incomplete information, or may just not want to provide all the information because of privacy. So this is something to think about when you're talking with your client. Recognition of non-traditional families. We see this more and more. Healthcare providers collecting family history should be aware of and prepared to document non-traditional families, such as non-nuclear families, multiple marriages, and offspring conceived through sperm or egg donors. Unknown paternity. Sometimes limited information from the paternal side of the family limits the reliability of risk assessment for disease. Sometimes a similar issue for adoption. In many cases, little may be known about the personal or family health histories of individuals who are adopted in and out of a family. Cultural definitions of family. People define culture, or in different cultures, people define family in different ways. And so it can be important to make sure that you and your patient are on the same page of who are you asking about and what are they defining as family. Cultural biases. Patient or provider assumptions can affect the collection of data and ultimately influence assessment and interpretation as well as patient management. So cultural awareness for the healthcare provider is very important. We've talked about consanguinity and how this can be a complicating factor in interpretation, and this might be an opportunity to refer or collaborate with a genetic specialist. And then last but not least, and this list is by no means comprehensive, confidentiality. We know from the literature and from studies that have been done that patients for the most part are comfortable talking about their family health history with healthcare providers in that trusted environment. But there are some circumstances where patients might view the collection of family history information as intrusive and potentially unnecessary. So it's important to be sensitive to this. So in addition to, we've talked about how family history can be helpful in identifying red flags, but family health history can also be helpful in providing opportunities for patient education. And Vaughn talked about this a little bit. Eliciting and summarizing family health history information can help the patient to understand the condition in question. So as you're collecting family history and talking about other people in the family who are at risk or who have the condition, this is a really helpful opportunity for patient education. You can clarify patient misconceptions about how a condition might be passed on in a family or their true risk for a condition. Educate them about the different, the variation in disease expression. So some people come into the office with a very fatalistic viewpoint. My mom had heart disease, so I'm definitely going to have heart disease. And this is a great, as you talk about the family history, it's a great opportunity for education. The visual representation is helpful for the healthcare provider, but it's also helpful for the patient, and that could be that moment where the patient really has a aha moment or things really click when you can see who in the family might be at risk for things. And it's also a great way to visually identify who else in the family do we need to collect some more information on, or perhaps obtain some medical records on people to complete the risk assessment. Okay, I think this is it for intervention. So what we've really talked about, for interpretation. What we've talked about here, after we've collected our family history, are to identify genetic red flags and be aware of the factors that are going to affect our risk assessment. And the next step now is intervention. How do we take all this information, our family history information that we collected, the red flags we've identified, the risk assessment that we're starting to develop, and actually implement a change for the patient that's going to result in improved care. So some of the key points or principles for intervention: we want providers to be able to identify where more specific information is needed and obtain records. We've talked about that. Assess general risks, take those red flags and synthesize that information for a risk stratification or risk assessment. Know when to refer to genetics professionals, and we're going to talk about this more in a moment. It's a great opportunity to encourage the patient to talk to other family members, and then it's also important that health professionals update the family history information at subsequent visits. So here we're going to talk about some of the different resources that are out there that you can refer your patients to, or that can help collect family history information. Vaughn talked about some of this, and some of these resources you may already be aware of. So this particular website we're looking at right now, talkhealthhistory.org, was developed through a collaboration between the Genetic Alliance and the American Society of Human Genetics. And up here we have the Surgeon General's Family History Initiative, which, as we've talked about, is a way that patients can enter their family history information into the My Family Health Portrait tool. Here we go, the My Family Health Portrait tool. And this is something that patients can do in the privacy of their own home, confidentially, and then generate a pedigree and bring that information to a health professional. The American Medical Association has some good resources on family health history. March of Dimes has resources on family health history and education for health professionals. And those are general resources, and now we're talking about resources specifically for finding a genetics professional. We mentioned earlier the National Society of Genetic Counselors. This is where you can click on this button, find a genetic counselor, and search by specialty area or zip code or many other features and find a genetic counselor in your area. Gene Clinics is another great resource that helps people find health professionals, and genetics clinics are registered here. And then the American College of Medical Geneticists. So this represents the geneticists, the physician geneticists who see patients in a clinical setting. And similarly, you can you can search by zip code, search by specialty, and find a medical geneticist and genetics clinic. ASHG, which we just talked about, American Society of Human Genetics, also has a database where you can search. And many of these resources, ASHG, NSGC, ACMG, they're linking you in many circumstances to some of the same health professionals, the same clinics. So you can start with one, and if that doesn't work, then go on to the next, but you don't need to look at all of them. Getting back to some general information on genetics, the Genetic Science Learning Center out of University of Utah is a great resource. The Genetic Alliance is a wonderful resource. And let me take a brief break and see if anyone has any questions before we get into case examples.
Do you feel pretty comfortable
So I unmuted everyone in case
with that
anyone
one section where she was saying how you can help people correct their misunderstandings or help them identify a correct condition?
No.
Yeah.
Because I'm not.
Okay, Emily, I think we can continue. If anyone has any questions, please just type them in for now into your webinar panel.
Okay, great. So we're going to go through a series of, I think, 4 case studies. And in each case study, we're going to look at 2 versions of a family history for a particular condition. We're going to look at someone who has an average or moderate risk, and then someone who has a high risk. And by comparing the different family history and presentations of these conditions, you'll be able to see what are the red flags that are different in an average patient versus a high-risk patient, and then what are some of the options available to patients in these different risk categories. So we're going to start with Sandra. Sandra is a new patient to your clinic, and she states that many individuals in our family have had cancer, especially colon cancer, and she's certain that she's destined to develop cancer in the near future. So I mentioned this earlier, this kind of fatalistic or very deterministic viewpoint that because people in my family have this condition, I know I'm going to get it. So this is a good opportunity to assess the family and educate your patient and determine if there are particular interventions that are appropriate for her. So how can taking Sandra's family history help to assess her risk to develop colon cancer? We can identify specific relatives with colon and other cancers. We can identify the ages at the diagnosis of cancer, identify family members who are unaffected, those who have not had cancer, and identify which sides of the family on which the cancer is present. So each of these steps is going to be important for assessing her true risk to develop colon cancer. And what we're really going to be focusing on is there a strong, what's her risk that there's a strong genetic condition running in the family. Okay. So in taking Sandra's family history, you find out the following information. She has, so here, let's again orient ourselves. It's always helpful to start with the person, your program, your patient. So we have an arrow pointing to Sandra. She's 46. You find out that she has a brother and a sister. Her mother is 76 and in good health, had no cancers. Sandra's mother's brother, her uncle, is 78 and was diagnosed with colon cancer at 59. Sonia's mother's younger sister, so Sonia's aunt, is 71 and had melanoma, skin cancer, at 52. And there's another aunt who's 70 and never had any cancer. These aunts and uncles all have children, but they have not, none of these children, none of Sandra's cousins have been diagnosed with cancer. Sandra's maternal grandmother died at 70 from colon cancer, diagnosed at 69, and her maternal grandpa died at 59 from a heart attack. So going over to Sandra's father's side of the family, Sandra's father died at 66, and we'll say he was diagnosed with colon cancer around that time, around 65, 66. He has one brother and one sister. Neither of these siblings has cancer. Sandra's paternal aunt and uncle have children, but none has been diagnosed with cancer. Her paternal grandfather died from lung cancer at 72. She reports that he had smoked for many years, so this could be an environmental risk factor. Her paternal grandmother died at 68, just from natural causes in her sleep. A lot of times people don't know what older relatives died from. So based on the information that we have here, we're looking for red flags. So what we see is that there are many people in the family who have had cancer, colon cancer, lung cancer, melanoma. And some people have had the same kind of cancer. So it's true that many people have been diagnosed with cancer. However, these diagnoses are not consistent with a hereditary or strongly genetic form of cancer. They're more consistent with cancers caused by environmental exposures or just that risk that we all have as part of the general population. Colon cancer is relatively common in individuals over the age of 60. And the individuals in Sonia's family who've had colon cancer were either more than 60 years of age or close to it. And it's also important to recognize size of the family. So yes, Sonia's had 3 relatives who were diagnosed with colon cancer, but 2 were on one side and 1 was on the other. So while there might be some variants coming through the family that are adding to her colon cancer risk, again, we're not suspicious at this point of a very strong hereditary cancer syndrome that's being passed down in the family. So based on this risk assessment, it's reasonable to consider Sandra at average or general population risk to develop colon cancer based on her family history. And for this patient, standard colon cancer surveillance would be appropriate. So we're not talking about increased surveillance for this patient, which hopefully would be reassuring to her with the accompanying education and risk assessment. All right, so now we're going to switch gears. Oh, sorry, I told you the answer. So thinking of a different perspective on Sandra's family. In this case, so this is still the same patient. Sandra is coming to you. She's 46, and she's saying, I have a strong family history of colon cancer. I'm very worried. I think I'm destined to get colon cancer. In this situation, her maternal family history is not changed. So she still has, her mom was still unaffected. She still has the uncle with colon cancer at 59, aunt with melanoma at 52, and grandmother with colon cancer at 70. That's unchanged. But her paternal family history has changed in this scenario. So here, the first thing that's changed is Sandra's brother. As part of a routine colonoscopy at 49, he was found to have precancerous colon polyps, colon adenomas, which were removed. He made sure to have a colonoscopy before age 50 because their father had been diagnosed at 50 and died at 56. And so that's a good recommendation to consider colonoscopy between 5 to 10 years younger than the youngest diagnosis in the family. Sandra's paternal uncle was diagnosed with colon cancer at 59 years of age, still living. Her paternal aunt was found to also found to have colon polyps during colonoscopy at 53. Her grandfather still died from lung cancer at 72. That hasn't changed, but her grandmother diagnosed with colon cancer at 52 and died at 54. This family history significantly changes Sandra's risk to develop colon cancer. So the previous example was an average risk for colon cancer. And when we think about this family history, we have some additional red flags here. Again, we have multiple people with colon cancer. And focusing on her paternal family history, we have 3 people on this side of the family who had colon cancer. All were diagnosed before the age of 50, some significantly younger, in her father's case, diagnosed at 50. And we have other people with precancerous polyps, which can be a precursor for colon cancer. So based on these red flags and synthesizing this information, it's reasonable to consider that Sandra has an increased risk or a high risk to develop colon cancer based on her family history. And this family history would also be suspicious for hereditary colon cancer syndrome. And what we would probably evaluate her for first is a condition called Lynch syndrome, or hereditary non-polyposis colorectal cancer. And this is something that that the healthcare provider could evaluate Sandra for, or refer her to a genetic specialist to evaluate for this particular hereditary cancer syndrome. At this point, given the information that we know, without knowing if she truly has a hereditary cancer syndrome or not, we would want to recommend that she increase her colon cancer surveillance over that of the general population until we can clarify the true genetic risk in the family to Sandra. So to summarize Sandra's case, there are a number of factors, and so think about the first scenario first. There are a number of factors that were decreasing her risk of a genetic basis to colorectal cancer in the first scenario. Colon cancer is common in the general population, as are melanoma and lung cancer. The affected relatives in that scenario were older at the time of diagnosis, and we had cancer from both maternal and paternal sides, which can sometimes be concerning, but it also reduces the chance that there's something strongly being inherited on one side of the family if we see a smattering of cancers on both sides. And in this scenario, we assessed that Sandra was of average general population risk. In the second scenario, there were a number of factors that were increasing her risk for a genetic basis to that colon cancer in the family. We had multiple affected relatives who were relatively young at the age of diagnosis, between 50 and 60. And we had multiple affected relatives, 3 individuals with those younger ages of diagnosis concentrated on the same side of the family. And because of this, we are more concerned about Sandra's colon cancer risk, so she should be referred for additional colon cancer screening. But we also are suspicious of a hereditary cancer syndrome, and she could be referred or evaluated by the healthcare provider for further genetic risk assessment, further evaluation for a cancer syndrome. So the things that we used to assess Sandra's risk here, we looked at family history collection with a focus on diagnosis and age, as well as affected and unaffected individuals. We looked at red flags. In this case, again, it was multiple affected family members and early age of onset. Those are our red flags. And our implementation of the risk assessment, or our intervention, was that assessment of her risk alters her recommended surveillance and potential referrals to specialists. All right. So our next scenario, again, we're going to present two versions that are slightly different. But the patient is Toby, and during a routine visit, Toby mentions that he is extremely conscious of his physical health because he does not want to get heart disease like the other members of his family. So again, we have a proactive patient coming in saying, I'm worried about my family history, and this is an ideal opportunity to engage the patient to assess the family history and provide education. How can taking Toby's family history help to assess his risk to develop heart disease? We can identify specific relatives with heart disease and some of the related or associated complications, identify ages of onset of the disease, and identify the presence or absence of risk factors in relatives with heart disease, because this will help and determine if we have red flags or not in the family. All right, so here's Toby's family. He's able to share a good deal about his family, and we'll go through this step by step. So again, orient ourselves to our patient. Here's Toby. He is 27 years old. He exercises regularly, and for some of this information, we can look at the legend to interpret it. He's physically active. He's in good shape. His cholesterol, that's what the C is, even though I don't, cholesterol is the C, and blood pressure is BP. These are within normal limits, W and L. Toby has a sister who's 34. His father is 58. His father is obese. Again, we can refer to our legend as needed. Has type 2 diabetes, high blood pressure, and high cholesterol. He had a heart attack at 55, so HA is heart attack. Toby's paternal uncle, his father's brother, is 61. He has high cholesterol and also has type 2 diabetes. His paternal aunt is 64, obese, and has high blood pressure. Similarly, Toby's aunt's son, which is Toby's cousin, is 40 and obese and has high blood pressure. Going up a generation, Toby's paternal grandmother was obese and a smoker for most of his life. He had a heart attack at 64 and died at 68. Looking at Toby's mother's side of the family, we really don't see any of these risk factors. And similar to W and L within normal limits, A and W means alive and well. These are notations you frequently see on pedigrees to signify that people are healthy and that there's no risk factors. So, do we think that Toby has a low, moderate, or high risk of developing heart disease based on his family history? Well, let's start with the risk factors. The risk factors for heart disease in this family include obesity, being overweight, smoking, and actually sex. Males are more likely to have heart disease. And we see, it appears that Toby's relatives with heart disease also have had one or more of these risk factors. So the way we interpret this, we don't see any instances of people in this family who are developing heart disease in the absence of risk factors. And heart disease is common, and people, and we know that there are a number of factors such as heart disease, such as high cholesterol, high blood pressure, obesity, lack of exercise, smoking, diabetes. These things can all be comorbid conditions and be risk factors for developing a heart attack and heart disease. So, it appears, based on what we see here, our interpretation would be that if Toby continues his healthy lifestyle and avoids these risk factors, he can reduce his risk to develop heart disease. So we would again put him at an average or moderate risk for heart disease, not a high risk, because he does not have any of the lifestyle risk factors that his family members have had. And so if he can stay healthy, we will give him a pretty good prognosis. All right, so now we're switching gears and going to a slightly different family history. Still looking at Toby, still presenting and saying, I'm very concerned about my family history of heart disease. In this case, his medical presentation and again his maternal family history are the same, the mom's side of the family. However, we've changed some details about his paternal family history. His father died at 50 after having had a heart attack at 49. He still had high cholesterol despite being, but in this case, rather than being obese, his father was physically active and of a healthy weight, an average weight. Toby's paternal uncle is 61, has high cholesterol and high blood pressure. Despite engaging in regular exercise, Toby's paternal aunt died at 48 from a heart attack. She also had high cholesterol. Her son, Toby's cousin, also had high cholesterol and high blood pressure. Toby's grandfather died at 55 from a heart attack. So in this scenario, what do we think of Toby's family history? Let's look at the risk factors. Here we have multiple individuals in the family, again, who have high blood pressure, high cholesterol, no more obesity. People are of a healthier size. People are exercising more. And yet we still see heart disease in this family. So we're still seeing people with heart attacks, and we're still seeing people with high cholesterol and high blood pressure, even though they live healthy lifestyles. So in this family, we have changed Toby's risk to develop heart disease. The heart disease present in his family members developed at a relatively young age and in the absence of risk factors. And though Toby is still healthy, it's reasonable to consider him at increased risk to develop heart disease because of his family history. While heart disease is a condition commonly seen in the general population and generally due to external factors, the strong family history of heart disease and comorbid conditions suggest a genetic component to the high diagnoses of cholesterol and heart attacks at a young age. Knowledge of his modified risk has implications for management of his health. So in this case, we say that Toby is at increased risk for heart disease. Again, we're going to think about first the original scenario that was an average risk for Toby. His risk in the first scenario, there were a number of factors decreasing his risk to have a genetic basis for the condition of interest in the family, the heart disease. The affected family members had multiple risk factors, some of which were environmental, and the affected relatives were older at the time they were diagnosed. In the second scenario, there were some factors that were increasing the risk that the heart disease in the family had a genetic basis. And these risk factors were that affected relatives were relatively young when they were diagnosed, and that these individuals were developing disease in the absence of risk factors. So in this case, we again used the collection, interpretation, and intervention or implementation of risk assessment. For collection, we focused on diagnoses and ages of onset and also looked at whether or not there are risk factors for those people who develop disease. We looked at red flags, multiple affected family members, earlier ages at onset, disease in the absence of risk factors, and disease in less often affected sex. And in this case, Toby's risk assessment of his family history alters his recommended health management. He is at increased risk for heart disease and should be managed accordingly. Okay, we're now on our third of 4 case studies. So this is Maria. Maria is a little baby. She's 1 month old, and she was born with a cleft lip and palate. Cleft lip and palate is commonly isolated or sporadic, but it can also be part of a number of different inherited syndromes. So that's what we're going to be looking at here. We're going to be comparing a situation or a scenario in which cleft lip and palate is most likely isolated compared to one that is most likely syndromic. And so you'll be able to see how those different family histories look. How can taking a family history help assess whether Maria's cleft lip and palate is isolated or syndromic? We can identify whether the features are present in other family members, and if that's the case, that might be suggestive of a syndrome. if features are present in other family members, we can identify an inheritance pattern. So this is something we haven't done in the other conditions. We've been focusing more on clustering of conditions and common conditions. And here we're going to think a little bit about inheritance and what that might look like in a family. Now, why is this helpful? We can better manage associated health problems if we find out if this classical palate is isolated versus syndromic. And importantly, we can determine recurrence risk for future children. And this would include if Maria's parents want to have additional children, perhaps more distant relatives like cousins, as well as when Maria grows up and wants to have her own children. All right. So here is Maria's pedigree. And Maria's parents are the ones who are reporting her family history, of course. So they report that they have another daughter who's 3 years old. So here's Maria. She's 1 month old, and she has cleft lip and palate. That's this colored in triangle. And she has a sister who's 3. The sister had no medical complications or any birth defects. Maria's parents are in good health. Her father has 1 sister who is reportedly a very anxious person, and she has 2 sons. Her older son has asthma, but there's no other health problems. Her paternal grandfather, had a heart attack at 59, and her paternal grandmother is 57 and reported to be in good health. So going to Maria's mother, and looking at her family, she has 2 siblings, a brother with high cholesterol and a sister. Maria's cousin on her mom's side is 13 and in good health, and Maria has 2 other cousins on this side of the family, boys ages 6 and 8 who are also doing well. Maria's maternal grandmother is 60 is 59 and has liver disease, but we don't know anything else about this information. And her maternal grandfather is 60 and in good health. So based on this history, it is likely that Maria's cleft lip and palate is isolated. Again, isolated cleft lip and palate is not that uncommon a birth defect. It occurs in about 1 every 1,000 births, or 0.1% of live births. There's no one else in the family who has cleft lip and palate, and no one else in the family who has any other birth defects or any other conditions that might be related to cleft lip and palate. So these are, and the things that we see in the family are things that are pretty common in the general population. So just some information about isolated cleft lip and palate. As we said, it occurs in about 1 in every 1,000 births, or 0.1%. And determining whether it's inherited is really important for being able to talk with Maria's parents about recurrence risk for future siblings. What is the chance that if Maria's parents want to have another child, that child would have cleft lip and palate? Based on the information we have here, that risk, if Maria's parents go on to have another child, the chance is between 2 and 8%. And the range there reflects, these are based on different studies that have been done, different population studies that have been done, studying families with cleft lip and palate, and the incidence of cleft lip and palate can vary slightly in the different studies, and that's why we quote a range to families based on the available information we have. The risk that when Maria grows up and has children, there's a 4 to 6% chance that each of her future children would have cleft lip and palate. All right, so now we are switching to a slightly different family history for Maria. Okay, so in this case, now we're keeping her paternal family history the same, and her maternal family history has changed. Maria's mother reports that school was very difficult for her. She didn't understand materials quickly as her classmates, and the kids used to tease her for talking funny. And so it sounds like she had some learning disabilities. When you talk with her, you notice what you classify as a hypernasal quality to her speech. She reports that her sister, Maria's aunt, has moderate hearing loss, and that when Maria's cousin, the son of this individual, was born, he was born with a heart defect and has been in therapy for a while because of his nasal speech. Maria's maternal grandmother was also born with, a cleft lip and palate and dropped out of school when she was younger because it was difficult for her to keep up with the material. So we're also seeing what it looks like learning disabilities in Maria's grandmother. So based on this information, what is our risk assessment? This new information is starting to paint a different picture than what we saw before, where we thought that the cleft lip and palate would probably be isolated. Here we're certainly more suspicious of an inherited condition. Although we don't see all of the same findings in all of the affected individuals, we see a clustering of potentially related features. And this is an important point. The red flags that come to mind in this case are multiple affected family members, early age of onset, and a point here would be hearing loss in a child is unusual, so that's an early age of onset, developmental delays or learning disabilities, and having one or more major malformations. So the cleft lip and palate and the heart defect count for these major malformations. Now the pattern here appears to be autosomal dominant. And when things are autosomal dominant, if an individual has an autosomal dominant condition, there's a 50% chance that each of their children will inherit that condition. So the pattern that we see here of grandmother to daughter to granddaughter, and that happening in a few different individuals being passed down, this looks pretty consistent with potential autosomal dominant inheritance of a syndrome. Now, the features that Maria's mother is reporting for her family members it could be suggestive of a few different conditions, but it's most suspicious of a diagnosis of 22q deletion syndrome. 22q deletion syndrome is an autosomal dominant condition, and it's due to a microscopic deletion of a region of DNA on chromosome 22. The main features of this condition include congenital heart defects, cleft lip and palate, learning difficulties, immune deficiency, hypocalcemia, characteristic facial features, and a few other features. It also provides important information for recurrence risk. Because it's autosomal dominant, as I said, there's a 50% chance that Maria's next sibling will have the condition. Because if we're assuming that Maria's mother has it, or if we're suspicious that Maria's mother has 22q deletion syndrome, then there's a 50% chance with the next pregnancy that the child would also have the same condition, and a 50% chance that the child would not inherit the condition. So this is much higher than our earlier recurrence risk estimates for isolated cleft lip and palate. This diagnosis is also important. It's not important. It's important for recurrence risk, but it's also important because it has implications for the health management of the affected individuals. And there are a number of conditions here that require monitoring. So now that we know that Maria is at risk for 22q deletion syndrome, we can refer her to a geneticist for further evaluation. And we also can monitor her for heart defects and screen her for heart defects and monitor her for some of these other things we see running in the family, like learning disabilities. So this is some of the information we just reviewed for 22q deletion syndrome. So let's think back to the two scenarios that we've looked at. In the first scenario, there were a number of conditions that were decreasing the risk that the cleft lip and palate was inherited. And those factors that were decreasing risk were the presence of, the only things we saw in the family other than the cleft lip and palate were things that were very common in the general population like asthma and anxiety. We did not see any features on either side of the family, but the conditions that were there were kind of evenly distributed on both sides of the family. And so there was no clear inheritance pattern or clustering within a particular arm of the family. In the second scenario, there were a number of factors that were increasing the risk of an inherited syndrome. And those included clustering of potentially related features, several genetic red flags, and what looked like autosomal dominant inheritance. The red flags, again, were multiple affected family members, early age of onset, developmental delays, and major malformations. And again, we We focus on collection, interpretation, and implementation. Okay, we're getting into our final case study, and here we're looking at Ann and Jeff. They are coming in for preconception care, preconception counseling, because they're getting ready to start a family. Following ACOG guidelines, the American College of Obstetricians and Gynecologists, Ann's physician makes cystic fibrosis carrier screening available to all of her patients and recommends that screening to patients who are of Northern European ancestry, who have a family history of cystic fibrosis. So Ann and Jeff are thinking about this test. How can Ann and Jeff's family histories help the physicians decide whether or not to recommend CF carrier testing or simply just make it available? And this is a situation in prenatal care where the ACOG guidelines say it's reasonable to offer this testing to all patients, but it's because it's a relatively common condition, and we know, and the carrier testing is a pretty routine test at this point. However, there are some families where if they have risk factors for the condition, you might want to talk with them more strongly about it and let them know that you have a higher risk than the general population, and to keep that in mind when they're deciding whether or not they want the test. So the family history can help identify whether CF is present in the family already, because that's certainly going to affect risk, determine whether there are ancestries for which CF carrier screening is recommended, and identify other family members who might consider carrier testing. So just a little background about cystic fibrosis. Cystic fibrosis is a multi-system disease. It affects pulmonary, digestive, and reproductive systems. Individuals with CF can accumulate mucus in their lungs, making it very difficult to breathe and increasing the frequency of pulmonary infections and complications. The digestive tracts of individuals with CF do not absorb food and nutrients effectively, leading to malnutrition and constipation. There can be reproductive implications for men as well. Males with cystic fibrosis have a condition called absence of the vas deferens, which leads to infertility. In the past few decades, treatment and management of the condition has significantly improved, and this is increasing the average lifespan of the individual with CF from childhood. It used to be that individuals would pass away in childhood, and now individuals can live on to young adulthood and sometimes longer. CF is an autosomal recessive condition, so both parents must be carriers of a CF mutation in order to have a child with CF. And if both parents are carriers, then there's a 1 in 4 or 25% chance in each pregnancy that the parents would each pass on their CF mutation that they're carrying and have a child with CF. So we're talking about a 25% chance for each pregnancy. All right, so let's look at our first pedigree. This is looking at both Ann and Jeff's family. Ann's reporting to us right now, so she has the arrow. Ann's 25. She has a 32-year-old sister with a healthy son. Her sister was diagnosed with mitral valve prolapse in her mid-20s, but it hasn't caused any problems. Ann's older brother has two 2-year-old twins, and everyone's in good health. The twins were delivered prematurely, but they don't have any health problems. Ann's father has diabetes, and her mother had a blood clot in her leg about 3 years ago, so this would be a DVT. Ann's family is mostly African American with a bit of American Indian. In talking about Jeff's family history, he's had migraines since his late teens, but no other health problems. He has 2 sisters. One of the sisters was diagnosed with irritable bowel syndrome at 31, but manages it well. She has 2 children who are healthy. His other sister and his other sister's daughter are also in good health. Jeff's mother, who's 57, was diagnosed with high blood pressure in her early 40s, and his dad is 56 without any major health problems. His ancestors are mainly from Northern Europe and maybe Russia. And as we talked about earlier, in cystic fibrosis, we know that there are certain ancestries in which people are more likely to be carriers. So we know that Jeff's Northern European background puts him at a slightly higher risk to be a carrier than Ann, because the carrier rate in individuals of African American and American Indian ancestry are a bit lower than individuals of European ancestry. So what is the chance that these individuals are carriers of a CF mutation? Well, the chance is pretty low because we don't see any family history of CF, and the only risk factors here really are the ancestry. And because we only have one individual who's of a slightly higher risk ancestry, it's unlikely that both of them are carriers of CF mutation. If one of them is a carrier, it's more likely going to be Jeff, but it's just based on probability when we know about population risk, so really it could be either person in the family. But again, we put them at a low or at least an average risk to have the CF mutation at this point. So now let's switch to our other family history for Anne and Jeff. So in this situation, Anne's family history is changing. Anne is now of Northern European ancestry, and she reports that her sister's 4-year-old son has cystic fibrosis. So what does this mean for our interpretation? It greatly changes our interpretation. Because of Anne's family history of cystic fibrosis, we know that she's at an increased chance to be a carrier now. And cystic fibrosis carrier screening should indeed be recommended to this couple in this situation. So to get into the detail a little bit, we would assume that Anne's sister is a CF carrier because she had a son with CF, and typically, in almost all situations, the parents of a child with CF are both carriers. So we know, or we assume that Anne's sister is a CF carrier who would have inherited from one of her parents, so that puts Anne at a 50% chance to have this mutation right now. So before, her risk might have been about 4%, this general population risk, up to 50%. So what we would recommend here is to first test Anne based on the family history, first see if she's a carrier. If she's a carrier, then we'd want to go on and test Jeff. If she's not a carrier, then that's pretty reassuring for the couple's chance to have a child with cystic fibrosis. Although a diagnosis of CF in one of their children may not change their pregnancy decisions, it still could be beneficial for Anne and Jeff to know the diagnosis as close to the birth of their children as possible, as the prognosis and management of CF is improved if interventions can be implemented early on. And many couples who would not change pregnancy decisions still express a desire to know what to expect if there's a genetic condition in the family. So this couple could be referred to, could be offered cystic fibrosis screening and or referred to a genetic specialist for additional counseling and evaluation. So in the first scenario, the factors that were decreasing the couple's risk of both being CF carriers, that Anne's ancestry had a lower carrier frequency and there was no family history. In the second scenario, the factors that were increasing the risk of both of them being carriers was that they are both of Northern European ancestry, which conveys has a higher carrier frequency rate, and there was a positive family history, and that's the big risk factor there. In this scenario, we looked at collecting family history, ancestry, and health information. We looked at red flags, including family history of the condition, ethnic predisposition, and what we know about autosomal recessive inheritance to interpret the family history of CF. And then our intervention for this couple is to talk with them about carrier testing, talk with them about cystic fibrosis, and offer them that screening test. If they decide they want that screening test, then there are a number of other prenatal testing options that might be available to them. And you can also, if you go on to carrier testing and they're both found to be carriers, then you can talk with them more about what would it mean to have a child with cystic fibrosis and prepare them for that potential diagnosis. All right. Well, this has been a whirlwind of case studies, but we're wrapping them up. So we've gone through 4 different case studies that compare a average population family history that highlights a particular condition compared to a high risk family history that highlights a particular condition. And I hope that that's been a helpful exercise to look at what are the red flags in a family that make you more suspicious about a genetic condition, about a strongly inherited condition, and what are the options available to a couple that are going to, or an individual that are going to impact management in those high-risk scenarios. So after this talk, what additional resources are available to you related to family history education? So this PowerPoint, or excuse me, this webinar will be recorded, so you can go back and look at it because there was a lot of information in these slides, and some of it we went over pretty quickly. There are additional training opportunities from professional organizations, different CME opportunities, and different professional conferences. The core competencies and other resources from NICHPEG, online resources that we've gone through, like at the March of Dimes, and various publications and resources, both in print and online, that you can access that talk more about genetics education and family health history. So to wrap things up, I'd like the people on the call to think about what opportunities exist within your practice to support the use of family health history. And as you think about that, think about what are going to be the challenges that you'll face to really implement family health history into your practice. Some of these challenges that providers find themselves facing when they're trying to implement new family health history initiatives include lack of time. There's so much going on in care, and this is one more thing to do. And there are some solutions that are available here that you can consider, like considering collecting the information outside of a provider appointment, asking patients to fill out a questionnaire ahead of time, etc. Uncertainty about how to collect and analyze a family history can sometimes be a barrier, and there are resources available, as we've just discussed, to help with this issue. Making family history easily available and updated so that it can be used by other providers and in current visits can also be a challenge. And we've talked about how it is important to stay updated with this information. So whatever system you use to implement a family history collection and interpretation program should be easily updated over time. Thinking about how to use family history to develop risk assessment and care plans is an important step, and there should be a system in place that providers can access to really apply some of the things we're talking about today and perform risk assessment and elect intervention and management options for a patient based on that family history risk assessment. This can be linking with finding people to refer to after you perform family history assessment and identify high-risk patients can be a big barrier for some, in some locations. Some people, there are no genetics professionals in the area, or for some patients, even if health professionals are pretty close, getting there can be a barrier location-wise. And we have identified in some links in this presentation to finding genetics professionals in your area, and we're also seeing an increase in genetics professionals who are offering telemedicine services. That can be an option sometimes when there are location limitations. All right, and I'm going to turn it back to Vaughn to see if there's anything else that she wanted to go through before wrapping this up.
No, thank you, Emily, so much for going through all of that. You can get a glass of water now. I have unmuted everyone, so if anyone has any questions for me or Emily, you can speak up now. Otherwise, I would invite everyone to please, if this is your first time going through the training, if you could fill out those surveys that we had sent around beforehand and make sure that those get to me and or Teresa via email or mail. I think everyone should have my contact information, vedelson@geneticalliance.org, and my phone number if you have any questions, and you can direct any of those to me, and if there's any questions for Emily, I can forward those on at a later time if they come up. I know that it was a lot to take in, so you might let those digest, and some questions might come to your mind later, and feel free to send those along.
Don, I just want to say that I really appreciated this refreshment because there's some things I had totally forgotten about that this has helped me. And we do have a couple of new doctors and a couple of other new staff that I'm going to get hooked up with the webinar. But I'm also going to take some of these slides because every staff meeting every month I do something to remind our staff about family health history. And I think I'm going to take a few of these slides and put them up and show them and talk about them to help get the enthusiasm back.
That sounds great, Marlita. Yeah, thank you for being here, and that's a good idea. I can send the individual presentation again if you don't still have it, so you can feel free to use, whichever size of those you want as a refresher. That's great.
I do have the other presentation. I still got that, and I'm sure most of the staff still have theirs too. I think they just need to revisit.
Perfect. And the recording will be available in about a week. I'll email everyone to let you all know when that's up, and then you can share it with your new providers and file the link away for future orientations.